that is place. I'm told that they do a lot of courses during the year, and one should go and visit that place. Over to you. Over to you.
Thank you very much. Thanks very much for the kind introduction. I can't see the audience, but I'm sure with time, hopefully, they will interact. The topic is distal rectal cancer or low rectal cancer. So what we know is about 1/3 of the cancers colorectal cancers arise from the rectum. When we say rectum, it is the Association of Coloproctology of Great Britain and Ireland defined as the distal margin of the cancer 15 centimeters from the anal verge. So if you take the anal verge, we do a rigid sigmoidoscopy. If the tumor is here, the distal margin is within 15 centimeters, then it's a rectal cancer. Beyond, it is a colon cancer. And distal rectal cancer, which is what we are focusing on, within the last 6 centimeters of the anal verge. So from the anal verge, you put a scope down, a sigmoidoscopy usually, and it's within 6 centimeters. It's called the low rectal cancer or distal rectal cancer. And in general, the goals of rectal cancer surgery are: one is looking at the survival, overall survival, disease survival, and there are chance of getting local recurrence. And downstaging is something new which has come up with the use of neoadjuvant chemotherapy or chemoradiation. Sphincter preservation, because people don't want to have a permanent bag. Temporary bag is fine, at least in the Western world. I know there's a big taboo about permanent stomas in the subcontinent. So sphincter preservation is very important. And then the quality of life issues, like the measures using the low anterior resection syndrome score. Also to look at the sexual and genitourinary function and treat morbidities. Like any treatment comes in with the complications, so we need to look at those as well. These are the goals in rectal cancer surgery or any sort of surgery. These would be the standard sort of goals we would be looking for. In rectal cancer management, I'm sure you all know, we do colonoscopy and biopsies and confirm the diagnosis. The management is by staging, the local staging and distant staging. Local staging is by MRI, looking at the circumferential resection margin, which is the margin around this area. I don't know whether you can see the MRI clearly, but that is the circumferential resection margin, which is what is looked at by the MRI. If it's an early tumor, then endoanal ultrasound is used to assess the tumor, and metastasis is assessed by CT scan of the chest, abdomen, and pelvis. In some places, CT PET is also used. Treatment is of 3 types. Usually, it's a surgery, radiotherapy, or chemotherapy. If the radiotherapy and chemotherapy is given before surgery, neoadjuvant treatment. After surgery, it's called the adjuvant treatment. Surgery is still the mainstay of treatment in colorectal cancer. Low staging, as I mentioned, a clinical assessment for which includes an examination anesthesia. In some cases, we do, because it is difficult to examine these patients in the clinic. And we do an MRI to assess the circumferential resection margin and the nodal status. And endoanal ultrasound is to look at the local T staging, and also inexperienced hands can be used in end staging. There's no talk on rectal cancer surgery without talking about the total mesorectal excision, which changed the local recurrence rate completely from about 30% to about less than 5%. This was used by Bill Heald. Basically, it's a standardized operation where you follow the mesorectal or the holy plane and do an en-bloc excision of the rectum along with the mesorectal tissue, which includes lymph nodes. So there is no leaving behind of the mesorectum, which unfortunately is the reason why people have the local recurrence. And the aim is to achieve a negative resection margin. And look at the results of the total rectal excision using the standardized TME approach, you can see that the local recurrence rate is less than around sort of 5 to 10%, and the survival is around 75 to 80%. And unfortunately, T is not without morbidity. It is good at curing cancers, but there is a high incidence of urinary dysfunction, which is about 20%, which we quote when we consent patients here, and the sexual dysfunction of 15 to 30%. Impotence is about 5 to 10%. And these have to be sort of put in the equation when we talk about rectal cancer surgery. And TME has got a high incidence of anastomotic leak because of the very low rectal anastomosis which we do, and we quote a figure of about 15 to 20%. And it certainly increased compared to the conventional surgery. Then there is a high incidence of low anterior resection syndrome, which is increased frequency. Patients complain of frequency, bowel fragmentation, urine urgency, incontinence. This is probably because of the sphincter damage or reduced compliance because of the rectum is removed. These are the potential risks with total mesorectal excision. The results of ultra-low anterior resection, this is even worse. They usually have a high incidence of incontinence, and stoma-free survival is a possible marker, which basically means that patients should be off the loop ileostomy, which unfortunately, when there was a survey done in Britain, about 25% of them keep the loop ileostomy. So it does not help the patient, giving giving a low anastomosis because you're not reversing the stoma. And the comorbidity with is about 1/3 of the patients have comorbidity. So low anterior resection, even though it's good at cancer clearance, unfortunately is not that good an operation in elderly, especially if one looking at restoring the intestinal continuity. Abdominal excision, there's a high incidence of, there used to be a high incidence of local recurrence. People felt it was due to the disease, less space, easy spread, and then this concept of cylindrical APR came up. We do this operation using a prone, as you can see, a prone specimen being retrieved, wider excision of levator ani, and decrease. This certainly showed that there's a decreased circumferential resection margin, positive rate, but unfortunately this comes down with huge complications as well. Like one of our patients who had a huge perineal breakdown, and this took a long time to heal, and we say that the complication rate is about 10 to 40%. Looking at the chemoradiation as an option of treatment, this is a study from Bergama where she showed that 99 of the 99 patients who had a complete response, which is about 20%. So 1 in 4 patients have a complete clinical response with just the radiation without surgery, and these patients have to be followed very carefully because there is about 15% chance of local recurrence. And if they develop local recurrence, then they can be still salvaged by having radical surgery, but this is in elderly. Complete pathological response where the tumor is completely removed, gone with chemoradiation, we quote a figure of about 15 to 30%. Concept of transanal excision, which includes TEMS or TAMS, endoscopic surgery, which is a minimally invasive surgery we do. This is really used for T1 or T2 tumors. Favorable T1 tumors have a local recurrence rate and survival rate similar to radical surgery. Unfavorable ones, which has got a high chance of a local recurrence, has got poor prognosis, and that is the reason why sometimes nowadays TEMS is combined with radiotherapy. In elderly patients, frail or high anesthetic risk patients refusing stoma, in early rectal cancers, it is still an option. Tumors less than 10 centimeters, and they are less than 4 centimeters in size, occupying less than 50% of the circumference, mobile tumors, and if there is a stage of T1 on ultrasound, where there's a less chance, 10% chance of lymph node metastasis, this is an option. These patients have to be kept on a close surveillance, as if there's any signs of recurrence, they need to be offered salvage radical surgery. This shows that the factors are also important, like if there is lymphovascular or perineal invasion, then there's a higher chance of lymph node spread, or if there's a mucinous tumor, then there's a high chance of lymph node spread and the recurrence, in which case one is offered radical surgery rather than local excision. The local excision is, we don't have any idea of the mesorectum where the lymph nodes are present, so there's no lymph node sampling, and deeper margin resection is a perirectal fat. So we say that the tumor is completely removed, but we don't know the stage of the mesorectum. But then, as I mentioned, when one looks at the formal resection and the local excision, the 5-year survival is less because of the higher incidence of local recurrence, and which fortunately means that in young patients we don't offer local excision surgery if fit and healthy. Up comes the role of robot nowadays, because robotic surgery is performed for rectal cancer. I've just got one slide which shows the benefit of robot. Basically, what advantage it adds is because you see the nerves better, then you preserve the nerves. So if you're doing a total mesorectal excision using laparoscopic or robotic surgery, mainly using a robot, if you preserve the nerves, there is a higher chance that patients won't have sexual and urinary dysfunction. Well, there is evidence for that. At the moment, it is not. We don't have the evidence, but we believe there will be evidence with time. And the main benefit of the robot, especially which came out from the roller study, which was comparing robotic with laparoscopic surgery in males, with low anterior resection in obese males, it is of benefit. But what the study showed that the circumferential resection margin rate was which was around 5%, and the complications were similar between laparoscopic and robotic group. There's a study from US which looked at the local excision for a T2 tumor, and they showed that there was a complete response of 44% and 64% had downstaging. Here, the protocol was patients had radiation followed by local excision of the tumor, and 99% of the patients had negative resection margin, and but then there was 39% developed grade 3 side effects from the radiotherapy, and there was high incidence of complications. So it's not like these techniques, local excision with chemoradiation without side effect. It comes in with side effects as well. And the T2 tumors, the disease-free survival was 88%, and one of the patients had GI side effects. The conclusion of the study was the disease-free survival was not high, but used in selected group of patients who have T2. This was for T2 lesion, where we say about 20 to 30% of them have lymph metastasis in the mesorectum. And the study in K called the TREC trial, and preliminary to the TREC trial, they did a small 4-center study looking at short course radiotherapy, which is 5 days for 5 days, followed by TIMS. 8 weeks later, this study showed 97% of them had R0 resection, and in the histology, 20 patients had no tumor, 23 patients had PT1, 18 had PT2, 1 had PT3, and the main thing was there was a good correlation with an ultrasound. So if ultrasound shows that it is T1, then patients can be put on this study where patients have short course radiotherapy followed by TIMS, and then when patients are followed up, they found that 4 of them developed local recurrence in the 2 lesions when they looked at their data, and 2 of them had salvage resection, and 1 patient had a stent put in due to comorbidity. So these patients are elderly patients who would withstand the standard radical surgery. So total rectal excision accompanies intact resection of the primary tumor with the regional lymph nodes, and TME reduces the local recurrence rate, improves the survival compared to conventional resection. Unfortunately, comes in with a huge amount of side effects and complications. Local excision is good at the moment for T1, T2, favorable biology. Now it's combined with neoadjuvant treatment. The lymphovascular status, adverse effects the term prognosis as there's the incidence of nodal disease. So in conclusion, ladies and gentlemen, at least the surgery, at least in the distal rectal cancer, is evolving. It is patient-centered treatment, not just looking at the tumor and say this is what you need. We need to put the patient factors like age, comorbidity, patient preference. If you want to have a stoma or not, to look at the tumor-related factors, to the disease, different to the tumor, mucinous tumor or not, lymphovascular invasion. If present, then there's a high chance the patient develops lymph node metastasis. And this the reason why there is a multimodality treatment and there is a need for multidisciplinary discussion. Thank you very much.
Last and we are going to learn that there are rounds for Can I take a liberty of asking the first question?
Yes,
Can I take a liberty of asking the first question? Just about this lower tier resection syndrome. How do you find it?
Sorry.
How do you quantify it? For a lower tier resection.
Probably. Sorry.
Okay, the low anterior resection syndrome. S.
Yes.
How common is it? How common is it? And how do you quantify it? How do you measure it?
Okay, there's a scoring system called the low anterior resection score. It has got 4 or 5 components to it, and it is subjective. Give the scoring sheet to the patient, asking them how are the bowel habits. Like if you Google it, you will get the scoring system. It is well regulated, validated scoring system, and based on the frequency of the bowel habit, based on bowel fragmentation, based on the urgency to open the bowels. And also there is another component which I mentioned to you in the presentation, which is urgency, bowel fragmentation, frequency, and incontinence. So you ask the patient to score it and then come up with the score. It is quite high. It is, I would say, about 30% of the patient. 1 in 3 of them will have some form of Lars syndrome. And with biofeedback and with physio, things improve. And unfortunately, these are side effects of the treatment what we give. And it is currently underestimated because we just focus on telling the patient that your cancer is gone. This is what we're going to live with. But you explore in deeper, we will certainly find at least one of the patients having problems because of the low anterior resection. It's basically because the rectal compliance is gone. And you've taken the rectum off, and the sphincters don't work well, so there is unfortunately the side effects of the treatment.
And how about the intersphincteric dissection?
Okay.
What are your views on the intersphincteric dissection from below?
Yeah. Intersphincteric dissection, basically, based on the MRI, the tumors can be classified as tumors just above the anal sphincter or involving the top of the anal sphincter or involving the full length of the internal anal sphincter. If it is involving the full length of the internal anal sphincter, we wouldn't recommend any restoration because there's a high chance of local recurrence. Those which are involving the just above the anal sphincter or in the top of the anal sphincter, we recommend chemoradiation, followed by, if the tumor is still adherent to it, then we would recommend an ultra-low anterior resection, which may involve removing the upper 1/3 of the internal anal sphincter. Problems with these are when you do this procedure, there's a high incidence of incontinence after surgery. So I wouldn't recommend this procedure in someone who is in their 60s or in women who have given birth to children, multiple children before. It's usually suitable for young men who develop, unfortunately, these low rectal cancers. So, but the main, it is not the technical exercise. Yes, you can narrow resection, but functionally they are not that great. And the studies, what has come out, they always have some form of incontinence. Patients have to be clearly consented about having a permanent stoma or occasional leak, because as they get older, they will have more leaks, and it is better to have permanent abdominal wall stoma rather than a perineal colostomy. So it depends on what the patient wants.
Okay, before I go on to the next question, can I say hello to Professor Ricardo or DCO? Ricardo, can you hear me? He has joined the meeting. I thought we will say hello to him so that he understands that we'll have his lecture when this one finishes.
Okay.
Ricardo, can you hear us? It looks like he has Professor Durrani's question. Professor Durrani.
Yeah.
Can you hear me?
Yeah,
can you hear me, sir?
Yes.
As regards low anterior resection syndrome, is it possible to give some benefit to the patient the way reconstruction is done, like something like coloplasty, etc.? So haven't they been able to considerably reduce the consequences that they are?
That's a very
reconstruction.
Basically, there are two or three ways by which you can do the reconstruction. One is a coloplasty, which is very popularized by Vic Fazio from the Cleveland Clinic, or doing a J pouch. The benefits of these coloplasty or the J pouch is only in the first year. After that, the results are the same. And unfortunately, these patients in the first year usually have a temporary stoma. So the benefit of these are not that great as what initially was thought. And as years go by, you will find that the patients' large scores slowly start creeping up, because the effect of the radiotherapy lasts longer. But in young patients, we can do coloplasty, or J pouch is difficult in young men because you can't fold the rectum, you can't fold the colon back and then do like a pouch because it doesn't fit in pelvis. But in women, we can try and do it. It provides a sort of temporary benefit, but in the long term, unfortunately, the results are the same as doing standard, straightforward colo-anal anastomosis.
Thank you. Just another brief question. When you talk of chemoradiotherapy, do you mean to say that this is the conventional radiotherapy for 5 weeks of time, or short course, which is in some part of the UK?
Yeah. When I say chemoradiation is the standard chemoradiation, which is the 5 weeks dose, which is used in the rest of the world, apart from the short course is specifically this 5 grays for 5 days and the surgery the week after, which is the one which came from the Dutch and the Swedish trial.
So why it is that this is a short course chemotherapy, if it is beneficial in terms of reducing the morbidity, not picked up by other colleagues across Europe?
Basically, if you look at the Dutch study, with the Dutch TME study, where they showed that if you do short course radiotherapy followed by T surgery, then you get a good response. But if there is a large tumor, you don't want to do this because you want to allow the tumor to shrink. And with the short course radiotherapy, you don't give that time in radiotherapy and surgery. Whereas with the standard radiotherapy, you give the chemoradiation followed by a gap of 8 to 10 weeks where the tumor shrinks and you operate. And that is a favored way of addressing rectal cancer which is T3 or a bulky tumor. Because with a short course, even though you give the radiation, you're giving the time for the tumor to shrink. So it is not an effective way of managing if it is a bulky tumor. And one of the reasons why it is not taken up as well as a conventional radiotherapy. And most of these tumors, what you see, are all not early tumors. They are sort of early bulky tumors.
Julia, can you hear my voice?
I can hear your voice. Yes.
Your voice is breaking.
I hear your voice. Yes.
We are lost the connection.
Hello, I'm here.
Okay, the voice is breaking now. It went very well during the lecture.
Hello. Hello. Yes.
Okay,
I can hear you.
we just temporarily.
Yes.
And I can also see Professor Ricardo Ardicio on the other side who has joined us in the meeting. Can you as well from Liverpool, Professor Ardicio, welcome to the meeting.
Hello.
Hello. Okay, Chilia,
Yes.
very nice talking to you. We had wonderful discussion and presentation. We're signing off from here. Thanks very much for contribution to the 9th Cancer Surgery Conference.
Yeah, I can hear you, Professor Chima. Thank you very much. Thank you.
Thank you very much. A big applause. Okay, a big applause. Okay.
Thank you very much.
Thank you again.
Bye-bye. Hope all goes well with the meeting. Good luck and best wishes. Bye-bye.
Okay, thank you again.
Bye-bye.
प्रेजेंटर का दो प्रेजेंटर का साइन
While they're making the Ricardo Ardicio,
होनी चाहिए Please share your screen. नहीं इनको मैसेज मैं करता हूँ नहीं उन्होंने अपना साउंड कनेक्ट नहीं किया अभी ना
Okay, so he is going to talk to us about how they manage axilla of people with breast cancer in the UK. आगे आपको है ना सुबह से बात कर रहे हैं. I invited you to tell us what do they do with axilla. So we are going to talk regarding management of axilla. And let's see. Oh, here you're connected to audio. Connected to audio. It says connected to audio.
ये अभी आ रहा है
Right.
नहीं आ रहा।
Hi, Ricardo. Gone on to a better.
आइस रॉनी है इसमें ना। नहीं उन ऑडियो आई नहीं आ रहा ऑडियो का ना, ऑडियो ऑन नहीं किया।
I computer for audio. I call he uses computer. Okay, while we are going to, we are waiting for it to come on. Basically, negative axilla, negative axilla, or positive. UK, that is axilla, and he has written a book. The editor of the book and editor of policy to the policy actually not clear. Originally for which but this is the rule. आपको फोन किया वो
आप अपना नंबर लिखिए, आप अपना नंबर लिखिए, आप बताइए। मैं
और वो के कॉल करने किसको मालूम है ना, आई विल कॉल इन।
नहीं सर, वो उस ऑप्शन पे जा ही रहे ऑडियो के, वरना वो दो अपने उनका मोबाइल भी कनेक्ट हो जाएगा वो भी।
अच्छा ठीक है, चलो उसका नंबर बताओ। तो आपका
How do we proceed here?
So, okay, hold on. We can hear you very well, and we are seeing your slides. Seeing your slides as well. Can you make them bigger? You maximize your.
वो कह रहा है कि I cannot see my slide.
Oh, okay. Because नहीं वो call in में है ना, वो call में है।
वो मोबाइल कंप्यूटर।
Okay, you have to use the computer mic so that because you're using the call in button and it is a separate mic. So,
Hi Professor, please connect the audio options by options and use the computer for.
मुझे वो टेलीफोन देना, उनका नंबर देना, अपना नंबर देना फोन पे। ओके प्रोफेसर ऑडियो शो। आप परेशान हैं अगर देखो की बात इसमें कहाँ करना है, ऑडियो में जाएगा ना, आप नहीं करेगा वो करेगा। अब आप मेरे पास दूसरी डॉक्टरों ने बात there is a tab which shows quick start on the screen.
बड़े गुस्से में आपने शोहर को